I am a psychiatrist at Mass General Hospital, and it is a great privilege to get to give this plenary to talk about bridging the divide and promoting equity in cancer care. And I really wanted to just highlight who's up here with me, which really speaks to the different people in the community who value this. So Dr. Jerry Rosenbaum is the chief of psychiatry, who's going to moderate our panel. Dr. Inga Lennis is a thoracic oncologist and senior vice president of practice improvement and service excellence at the Mass General Physicians Organization, an amazing systems thinker about how to get stuff done. Next to her is Dr. Emma Stanton, who is an advocate, a psychiatrist from the UK, and a leader at Beacon Health Options, which is a mental health payer, which is doing a lot of innovative work. And next to her is Dr. Kathy Sanders, who many of you know, who is Deputy Commissioner and Medical Director of the Massachusetts Department of Mental Health. And next to Kathy, we are honored to be joined by Representative Christopher Markey from Dartmouth and Fall River, who also has a particular interest in ethics. So after I speak, we're going to transition to the panel. I think that starting with these stories is such a great way to start. For me, it really centers me. And then I look out into this room, and I think how often on the front lines, like Karen was talking about, that you feel alone. You're not sure what to do. It's complex. You want to help the person in front of you, whether you're a psychiatrist, an oncologist, a nurse, but you're not really sure. And so it's very gratifying to look out into this room and see the different stakeholders who can collaborate to create solutions that work. It's not just Mass General, but multiple health systems, multiple universities, health systems from the Western Massachusetts, people doing really innovative things like Commonwealth Care Alliance. All of these people independently chose to come on a Friday afternoon because they care about this topic. Additionally, it's not just hospital systems, it's community mental health agencies, health centers, insurance payers, the state of Massachusetts, all coming together because they care about this issue. And finally, I really want to take the moment to recognize the patients and families who are out advocating for this event, and the groups that advocate for patients with mental illness and cancer, including the American Cancer Society, the National Alliance of Mental Illness, and the Depression and Bipolar Support Alliance. And so I think with that frame, we are going to talk about integrating psychiatry care into cancer care in a rigorous academic way. We're going to talk about how important our research agenda is to change practice on a national level, and what a privilege it is to do that kind of research here in partnership with the Mass General Cancer Center. We will also talk about how we're going to make that research relevant. And that is the work of all of us in this room, so that that research doesn't stay in the academic cancer center. It also goes out into the community, and it helps people who are on the front lines get the care that they need. So serious mental illness is common. 13 million people in the United States live with schizophrenia, bipolar disorder, and major depression. We do not have enough treatment. 90% of schizophrenia is untreated. And psychiatric illness, when it's combined with medical care, it leads to more time in the hospital, more emergency room visits, greater healthcare costs, and even more important, it's just a system that doesn't work for these two complex issues happening at the same time. So people with serious mental illness die 15 to 30 years earlier than the general population. If we just take a moment, the latest research shows that people with schizophrenia die nearly 30 years earlier than the general population. 30 years. What do they die from? Where does that disparity come from? I often hear that it's because people die from suicide or from violence, but the number one cause of death in patients with serious mental illness is cardiovascular disease, and the number two cause of death is cancer, much like the general population. Yeah, no, I think that's definitely a piece of it. And I think that speaks to the fact that this is preventable. This is something we can do something about as a group. What's sobering to me is that this gap is widening. And that means we need to do something differently if we're going to start to close it. So to speak specifically about cancer, which is where my research and clinical career is focused, individuals with serious mental illness are equally likely to get cancer, but more likely to die from it. Twice as likely to die from breast cancer, lung cancer, colorectal cancer, head and neck cancer. When we think about a mortality disparity, you might wonder, is this because of some biological difference? No, that doesn't seem to be the case here. Instead, we need to start thinking about the processes of care. And if we look at a specific example, I mean, it's really a testament to the amazing medical system that we have access to and that many people have access to. You know, here in Boston, that breast cancer survival has improved from 75% to 90% over the past 30 years. However, not all groups have benefited equally from those advances in treatment that require access to multimodality treatment, early detection. These are the places where we're falling off for people with serious mental illness. So it's very important that we can target these inequities throughout the cancer care continuum. People have less screening, less access to tobacco cessation, and that leads to delays to diagnosis and treatment. People are less likely to get timely, stage-appropriate cancer treatment when they're diagnosed. People are more likely to be lost to follow-up, and they also have less access to palliative care. And although research in this area is very limited, we are starting to learn that those inequities in cancer treatment contribute to their premature cancer mortality. Well, it's good to know that disparity exists, but that's not enough, right? We want to identify things that we can do to start remediating that disparity. So what kind of research can you do to start identifying those kinds of solutions? That's what I care about. As a clinician, fundamentally, that's who I am first, right? And we didn't really know very much about the process of cancer care. So the first thing we did is we looked within an academic cancer center and patients with schizophrenia and breast cancer. And we found that 50% of them had meaningful disruptions in their cancer care. Now this is best case scenario, state-of-the-art treatment, well-resourced. And we looked at the kinds of disruptions that are linked to poor cancer survival. If we think about comparing that to people without mental illness, fewer than 20% have these kinds of disruptions. And we tried to identify modifiable factors, and we found that lack of psychiatric treatment at the time of cancer diagnosis was the most powerful predictor of which patients had those kinds of disruptions. It wasn't how old they were or where they lived or what type of insurance they had. It was whether or not they had access to psychiatric care. So hopefully that's heartening and that's something we can do something about. And so if we take a step back to think about the patient, clinician, and systems-based factors that contributed to inequities in cancer outcomes, we can see that we're arguing is that those impact the continuum of cancer care, and that downstream, that leads to poor cancer survival and poor quality of life. So specifically, what about at the patient level? A piece of it is uncontrolled psychiatric symptoms. So oncologist says people fall off the grid when they get ill and stop taking their meds. They don't go home to a roommate, a family, they don't have anybody there. And what do you do about that? Well, it's always heartening to me when an oncologist says, it's like hypertension. You treat the disease and it gets better. That's a frame that isn't always brought to mental illness, and it's a helpful frame to say, this is a medical condition happening at the same time, let's do our best to address it. And what about for clinicians? Well, there's some realities, that we have less experience with populations that we see less often. And oncologists, when we did qualitative interviews with oncology clinicians, they spoke to having limited comfort with the population, having limited training in serious mental illness, and also having limited time. And one oncologist telling me it takes me 2 to 3 times longer with this population, which is the reality. So we need to come up with systems-based solutions to help oncologists with this. And of course, it's easy to feel overwhelmed. They're not trained to talk about cancer with schizophrenia front and center. They do need a team approach, as one medical oncologist said, just about more than any other patients we see. And what about the system? Well, right now, our system is pretty fragmented and there's not enough access to psychiatry. One of the biggest barriers is lack of access to psychiatry, and with cancer care, we can't wait. And from the community perspective, they don't know who we are, they don't see the value in having us involved. And on both sides, as someone who walks between those worlds, they would say, well, they never call me. I can never reach them. I don't really know who to call. They're complex systems, both of them, and we need to figure out some bridges. So if you Google Cancer Center and you Google mental health clinic, these are the images that come up. For me, this reflects stigma, which we've been talking about already today. It reflects the level of investment we place in the infrastructure of our health systems. It also reflects separation, the fact these are different buildings. Different clinicians walk into them. They don't share a medical record. It all makes it harder
for the most vulnerable patients, or some of the most vulnerable patients that we treat. And finally, just to make a point from the research perspective, people with mental illness are systematically excluded from research. 50% of high-impact randomized controlled trials in high-impact journals, the best kind of research that we all look to guide our practice, exclude mental illness. Without really saying why, providing a rationale. If we look in cancer, 25% of lung and colorectal cancer trials, and collaborative care trials, which are about integrating behavioral health and medical care, they also exclude people with pre-existing serious mental illness. And as the oncologist said, there are people who probably don't offer appropriately aggressive treatment. They might assume patients can't give informed consent or won't understand. People do write off this population. But I think it's also because people feel helpless. People want their trial to be a success. People want to not hurt their patients. And so what they really need is tools to help them do the best possible thing. And so what we try to do is figure out whether we can learn about how to do research with this population and how we can use this new model of care. And so I'm going to take you through our model. Now, it's a team approach. So the social worker and case manager that I work with is right there. Her name is Amy Corvalline. I could not do it without her. If you think about a traditional visit, Dr. Ryan was saying earlier, there's a doctor and a patient. Fundamentally, there's this interaction between a doctor and a patient at cancer diagnosis. And maybe they engage the caregiver if that person has a family member who comes, and maybe not. But maybe that this model doesn't work as well for our population. So what if instead everyone got a proactive psychiatry consultation at the time of cancer diagnosis, and together we came up with an integrated treatment plan that addressed both? And what if also we involved the social worker, nurse case manager, who could start bridging that fragmented system and engaging the patient and their caregiver to be advocates for themselves? And what if we put the patient at the center of that model, and we said, we're gonna see you no matter what setting, if it's in the inpatient hospital, or if it's at rehab, or if it's at home, even if it's 5 o'clock and I don't really know if it's my job, which are all the things I hear all the time. We're gonna try our best to do it anyway, and I'm very lucky to collaborate with people at Mass General who share that ethos. And starting with the patient, I think, is the key to building that trust. So this is our model. And we wanted not just to say this is a great clinical model, but we wanted to conduct rigorous research to see whether it was possible to conduct a trial using this model and integrating it into cancer care delivery. So our aim was to evaluate whether this model was feasible, whether we could do it, right? And whether it was acceptable to the people that mattered. So to patients, to their caregivers, and to oncology clinicians. So this is the study we did last year. It's a pilot study. We weren't comparing it yet to any other intervention. We were targeting people with schizophrenia, bipolar disorder, major depression, with a prior hospitalization who had been recently diagnosed with some of these 4 cancer types which we knew were linked to increased cancer mortality. And that was pretty much it. So we didn't care if they had comorbid substance use, or if they had a guardian, or if they were homeless, or if they were challenging. We took everybody. And that was a really important part of the framework. It was a 12-week intervention where they had a proactive psychiatry consultation. They were linked to a case manager, and we communicated with their oncologist. And we tracked how they did with their cancer care, but in this pilot study, we really focused on whether or not we could recruit people, consent them, keep them in the trial, and what was the feedback from the key stakeholders. So how did we identify people? Because I can tell you that people said to me, there are not people with serious mental illness in the cancer center. I mean, there might be a few, Kelly. I'm like, I think there's a couple. So we tried to systematically identify people with serious mental illness by screening every new patient evaluation in the cancer center for mention of serious mental illness. We did that. We also had champions like Dr. Lennis, like Dr. Ryan in the cancer centers who advocated for us, and they knew me. I worked there. They knew I was helpful. So they referred us patients. And we also formed strong partnerships with many of the people in this room, with leadership at Bay Cove and North Suffolk and the Department of Mental Health, who, like Karen, just by happenstance happened to refer me that patient. She participated in our trial. We consented her to the trial at the same time we brought her into the hospital. The same day I met her, we consented her, we enrolled her. And she was able to complete her treatment. So what do you do about this? We decided up front, how are we gonna tailor procedures? Knowing someone might be both cognitively limited, have poor attention span, have a difficult time thinking abstractly, and be scared or paranoid about written information, let's not do a written consent. Instead, let's do a verbal conversation where a clinician talks through the risks and benefits of the study, and then takes additional time to document that patient's assessment of capacity. Because that actually makes sense. We're trying to give people the optimal ability to understand. And given the fragmented care, what if we meet them wherever they are? And what if we link our visits to the oncology visits? And that was like the core of our approach. So again, we are looking, our primary outcome was feasibility. So feasibility of enrollment into this trial. As David said, I think it initially was 18 months. I'll say 12 months here, that 50% of the people we approached would consent to the study, and that 75% of them would complete the study. And then we also conducted exit interviews to understand how it was acceptable and useful. So who did we enroll in this study? In some ways, they're very different from other patients who are treated at the cancer center. So few people were married. Only 14% lived with a partner or spouse. Many were homeless, although it says just 3 at the time of enrollment. I think that a third of the people in our trial had been homeless at one point or another. It's very different. So our standard cancer center population, 70% are married or partnered. And who their caregivers are is just very different. 64% disabled, nearly 70% making less than $25,000 a year, the majority having Medicaid or both Medicaid and Medicare insurance. And these are sick. These patients had severe psychiatric illness. I work in the schizophrenia program. These are amongst the sickest patients that I've worked with. They had been hospitalized recently. And we were able to get good representation from bipolar disorder, major depression, schizophrenia, the different cancer types, and different cancer stages. When we asked people at baseline, what were their experiences like of being treated differently? Did they have these experiences? How often? So nearly half of the people said that they were treated with less respect, or people acted like they weren't smart, or they weren't better than, or they were better than them, or that people were afraid of them. And mental illness is the reason that they attributed to that discrimination. And who were the caregivers in our trial? So like Karen Metzger was alluding, a third of the caregivers in our trial were community mental health staff, whether they be nurses or nurse practitioners, psychiatrists, or group home managers. So could we do it? So we learned that yes, this intervention was feasible and that there was significant unmet need. So we were able to meet our recruitment goal, 30 patients in 4 months, and we turned many people away. 88% of the patients who were eligible for the trial consented to the trial, or their guardian provided consent, and 88% completed all the phases of the trial. People found it useful. You can see 96% of patients reported that it was useful or helpful to meet with a psychiatrist. Many people found it helpful to meet with the case manager. Caregivers too, whether they be siblings or children or parents or spouses or community mental health staff, found that the intervention addressed key challenges and that it was helpful. And oncologists and oncology nurse practitioners also found that the intervention was very useful. And the great majority also reported that it positively impacted cancer care. So in our exit interviews, we gathered words from patients, their caregivers, and their oncology clinicians. And some common themes emerge. So for patients, like for all of us, you have to feel cared about first. So she listens, you can tell. Learning I was not alone. That had to come before managing symptoms. I'm always thinking, and sometimes meeting with the team helps me think in the right direction. And before resources, even though that also was critical, she got me into rehab, taking the burden of my care off my daughter's shoulders. And the importance of a team approach. It took a whole village of doctors to get me through this. In the words of someone who had severe depression, previously hospitalized, prior substance use, became homeless, had had a stroke, and oh, by the way, had head and neck cancer. And we got him through it, through a lot of interdisciplinary collaboration and teamwork. Caregivers bring up some of the same themes. They talk about how important it is to be holistic and person-centered. You got a team approach for the whole person. And they talked about how critical it was to have access to psychiatry during cancer treatment, that how often it would get lost, that mental health piece, and that having that present there during acute illness was helpful. They talked about being so grateful they were engaged in the care process, that we brought in family members to lead family meetings and express things in language that made sense to them. This woman had refused radiation treatment for 2 months. I kind of kept saying, can you mind if I call her? You know what the heck, I'll call her. What's the harm, right? And so they're fine, call her, Dr. Irwin. Stop bothering me about it. So we called her, met with her once, we brought her in again, and we met with her brother. And she said, okay, sure, I'll get my radiation. She got 6 weeks of curative radiation treatment. And basically at the end, she's like, oh, it wasn't so bad. Thank you. Thank you for telling me it was important. And I think that, so advocacy is also critically important. We can get lost in autonomy sometimes about making sure that we're honoring people's wishes. And it's true, I think sometimes you have to have someone say, you ain't dying on my watch. You think about what we would say to a family member who wasn't getting care. And I think it's critically important to have someone who gets oncology and schizophrenia and can distill that into language that makes sense for community staff members who are on the front lines and be available to communicate with them. Oncologists, also spoke about how helpful it was to care for this population, that it changed how comfortable they felt, how confident they felt, knowing that they had a team approach and had psychiatry on board, that they could actually accomplish something, that it made sense to recommend stage-appropriate treatment and really do our best because we had a team approach to doing it, as opposed to kind of losing hope. And that it additionally mattered that we were proactive and flexible and available throughout the course of treatment to work together. As one oncologist said, in a dream world, I'd call psychiatry and we just go see patients together all the time. So that would require more than one of me. Okay, but they also spoke about impact on cancer care. And this is a small pilot study. It's a single-arm pilot. It is just the beginning of the rigorous research we will do. But there were patients who it was pretty clear they wouldn't have gotten care because they were not engaged with the system. We brought them in and engaged them. An oncologist said she would not have received her cancer care otherwise. I don't know if we would have gotten him through his treatment without psychiatry. Managing his symptoms allowed him to complete treatment. You heard about this patient, and Karen Metzger said it better than I can in the words of, this patient's own words. But this is what she said to me. If I were alone, I would have run away. This is a patient with stage 3 lung cancer who did run away from her clinic, right? And no one told the nurse practitioner what to do. Finally, someone just had to say, well, let's bring her in. And she's come a long way from not wanting anything or any information. In fact, people said, I've never seen her look this well. She must trust you. I'm glad we could see her together in the hospital. The radiation oncology team's on board too. So what does all of this mean? So to me, I think it's first important to remember that this disparity is unrecognized. Many health professionals, let alone the overall community, do not know this information. So take that with you. Spread the word that individuals with serious mental illness experience premature cancer mortality, that there is this 30-year mortality gap, and that is driven in part by inequities in treatment, that we can do studies in patients with serious mental illness and integrate them into care, that this particular model looks to be feasible and acceptable and it shows promise, and that we need to do more research, rigorous randomized trials to investigate the effectiveness of this model at improving cancer treatment. And not just the research, but we need to do stuff like we're doing today, which is, I hope, just the beginning of what we'll do together as a community to increase awareness. I mean, what a gift it is to have people from the government, from policy, from community agencies together brainstorming about this, right? To build meaningful community and academic partnerships like we've built with the Department of Mental Health. We said, okay, we're just gonna consult you. We're gonna make this happen because we know people aren't getting access to care. Let's figure it out along the way. And I think that in terms of changing hearts and minds, we've talked a lot about stigma. But I had the gift of seeing a very compelling talk by two people who led the campaign for marriage equality in Ireland. How did they convince people who had such steadfast beliefs of what that meant to be gay in Ireland? And they told me something which I found very compelling. They said, we went out into the community and we talked to grandparents and neighbors and friends, and they shared their experience of mental illness, or not mental illness, but of what they want for their family member, right? It's the same thing, that I want my family member to be treated with respect, that everybody's life means as much, and when we start putting things into human terms, that's when real change happens, and I think that's something that all of us in this room, no matter our clinical training, can contribute to in a really rich way. And so this is Jonathan. You know Joan. He was a really great skier. He was had great fashion sense. Joan told me he would have approved today. His care was very challenging. I don't want to not say that out loud. He was medically complex. He was in the emergency room. And really, his care really only could have happened at a place that had access to psychiatry treatment and cancer treatment together. It's rare. We need more of it. And not everybody or anybody really has an advocate like Joan. So imagine how hard it would have been without Joan. And so then before we turn it over to the panel, just a quick thank you to all of the people who are here and to the Dana-Farber Harvard Cancer Center and MGH Cancer Center for giving us, this academic forum and community forum to increase, awareness and start together to think about how to move forward.